Hey guys, so we are going to do the second section of chapter 21, where we are starting to talk about the different types of organisms that will infect the different systems. So we're talking about skin and eyes in this chapter, and so we're going to start with bacterial infections that are going on in the skin and the eyes, and then we're going to move on to viral and fungal and helminths. So our first one is staph. And if you have been playing around in lab, whether it is virtual or face-to-face, hopefully you are getting able to see these guys. So staph, when you look at these guys under the microscope, these guys are going to be gram-positive. So they're going to be purple, and they're going to have a coccyx shape, and they cluster together. So these look like purple grape clusters underneath the microscope when you're checking them out after you have gram stained them to differentiate the two different types that you could get, gram positive or gram negative. These are gram positives. Are staph. There are different types of staph. You are going to have a few different types on your body all the time. We talked about biomes in the previous video. So staph epi is on us in all sorts of places, and it's generally harmless unless it gets into places it shouldn't go. Staph hominis as well, relatively harmless as long as they stay where they're supposed to stay and don't go where they're not supposed to go. Staph aureus sometimes can be harmless. There are strains where Staph aureus is pathogenic. So how do you differentiate between the different types? They do have more virulent strains. So the more virulent ones, such as in Staph aureus, may have things like staphylolysins, and those guys are going to be cytotoxic, which means that they will kill cells. If we talk about cytotoxic killer T cells, that's what they're doing. So they can be cytotoxic for different cells like white blood cells, skin cells. They may be coagulase positive, so that's a differentiator when you're trying to test and see, is it staph or is it strep? If it tests for coagulase, it's going to be staph. It may have leukocidins, which are specific white blood cell killers. And then it is going to be a contributor for toxic shock syndrome. Toxic shock syndrome is going to be produced by Staph aureus. So any of the ladies out there, if you have looked on the side of your feminine hygiene box of tampons, you have seen the little paper thing about toxic shock syndrome. That's also Staph aureus. So how do you know what staph you have? Because again, I said some of these guys are pretty harmless and some of these might be harmful. They might be pathogenic. So how do you know if you have Staph epi or Staph aureus? First, you need to know if you have staph. And we said it was gram positive, so it's purple. It's coccyx shape, so it's spherical shape in its clusters. These guys group in clusters. So you know you got staph. What staph do you have? Hopefully, if you're in face-to-face, you get to make a plate just like this. Labs to labs, sorry guys, labs to labs are a little bit different. But this is our mannitol salt plate. And so we talk about selective and differential types of media. This is one of those. So it's going to differentiate between the different types of staph. Are we looking at Staph epi or are we looking at Staph aureus? So Staph epi is going to be here, and it's not going to be able to ferment the mannitol, but Staph aureus, this is Staph epi, and this is over here on the left side. It's going to be Staph aureus. Staph, I'm just going to put A there for Staph aureus. And so it ferments that mannitol, and it will change it from red to yellow. So if you run a plate and your plate, after you incubate it, grows yellow instead of red on your normally mannitol salt just looks red. If that color changing happens, it is fermented and it's a pH change and it causes it to change from red to yellow, you will see that and you know you've got Staph aureus. Some of us have Staph aureus, like Staph epi is pretty much all over. Staph aureus likes to hang out in your nostrils, and some of us are asymptomatic for it. We don't even know that we have it because we talk about typhoid Mary and being asymptomatic. So some of us have Staph aureus in our nostrils, and you may not know it because you're asymptomatic. But when you go and do the lab and you're able to take a swab of that just on the inside of your nose and then put it on a plate, shocker, you've got it. So this is a really good differentiator. The mannitol salt plate can tell you, are you looking at Staph aureus or are you looking at Staph epi? And here you can see that, again, the grape clusters that they look like for staph. So staph, just to sum up, it's going to be able to, Staph aureus is going to be able to digest the mannitol, ferment that mannitol, and change the color. It is going to be, staph is coagulase positive, so that is another test to see if what you've got going on for them. So here, where you're trying to see, do you have Staph aureus, do you have Staph epi, or is it strep, which we're going to talk about next. But we said coagulase positive is going to be coagulase test, OBR staph, and our strep is not going to have it. Catalase, yes, and strep is a no for those guys. So those are some tests that you might be able to see and differentiate between the two, coagulase, catalase, and see what's going on. And if you have catalase is positive, coagulase is positive, mannitol salt is also positive, then you're definitely looking at Staph aureus. So different ways to diagnose these little guys. What does the staph infection look like? I was telling y'all about my daughter when she was itty bitty and baby, and she got a staph aureus infection. She got MRSA. It was methicillin resistant because it wasn't, I put Neosporin on it, it wasn't doing anything. It was because it was MRSA, and so she had to have heavy dose antibiotics to try and get rid of that. But this is what staph, examples of different types of staph infections look like. So we have folliculitis, furuncles, and carbuncles. So here we are going to have a furuncle. That's this guy. It doesn't look nice. It's not. It's going to have pus in there, these dead white blood cells in there. It's producing pus. It's purulent as a furuncle. Carbuncles are pretty much just a whole bunch of furuncles together. So this big nasty group of furuncles is going to turn into a carbuncle, and those are just like the furuncles. They are pus filled, but it's usually deeper. It's just a deeper, bigger wound when all of these things get combined together. So that is this one. This is the furuncle, and this is the caruncle over here to show you those infections and those pictures. Other staph infections could be Staphylococcal scalded skin syndromes, SSSS4S. This is coming from, not Staph epi, because I told y'all that that one's pretty decent as long as it stays where it's supposed to. Staph aureus can cause this. And so it causes the skin to turn red first. It's going to have erythema. It's going to turn red first. And the toxins produced by the Staph aureus will cause that redness, and then it peels. It's like, it's red, it's not happy, and then it starts to peel, flake away, rub off as this infection runs its course. So some antibiotics can take care of this situation, but it doesn't look good on baby's hands at all over here in this picture. Impetigo is usually if staphylococcal scalded skin syndrome, my goodness, 4S's, if that shows up in babies, that we can typically get that under control. Older kids, though, may be prone to this guy. This is impetigo. It could be from Staph aureus, again, the culprit for lots of things. But it could also be strep. So when we're talking about, is it staph, is it strep, what test do we need to do? It could be strep pyogenes, or it could be a combo of Staph aureus and Strep pyogenes. It just depends. But it's going to have pustules, maybe BIOL, and these are blisters, and that they will pop, they crust over. Um, it's not so fun. It's not to have fun thing to have, but some typical topical or oral antibiotics should be able to get this under control. Nosocomial staph epi infection. So I told you staph epi is relatively, safe-ish as long as it stays where it's supposed to. But if staph epi gets where it shouldn't be, like in a nosocomial, so somebody's undergoing a procedure and they need a catheter or some sort of something else in their person, and that gets infected and covered with staph epidermis, and it's going inside of your body where it shouldn't be, and all of a sudden it has all these nutrients, and yay, it's going to go gangbusters. That's not good. You don't want that to happen. And that could happen in a hospital-like situation, in a nosocomial situation with staph epi when it gets to go into places where it normally shouldn't go. All right, so those were staph. Let's move on to the strep that we were talking about when we were comparing staph versus strep. Strep is also going to be gram-positive. It is also coccyx shape. It's going to be in chains though, where staph epi was clusters, little grape clusters. Staph strep pyogenes is going to be in chains, so just like this, and that looks perfect, like a chain right there. When you grow these on the sheep's blood, on the blood agar, you can possibly be able to differentiate the different types of strep pyogenes. Sometimes you won't see it hemolyse at all, so it'll just grow and not rupture the red blood cells in the agarose. But sometimes you're going to see alpha hemolysis or beta hemolysis. It just depends on what you're looking at. These guys are facultative anaerobes, and they are catalase negative. So if you are testing for catalase and it's positive, we're looking at staph. If it's catalase negative, we're looking at strep. These are also going to have virulence factors, just like staph did, and it was talking about different virulence factors. So group A, strep, could have some virulence factors like enzymes, streptolysins, hyaluronidase, streptokinase. All of these help it make the tissue around it not happy, become inflamed. Some of these guys, again, are hemolytic, so they will just rupture those cells. They are capable of producing a capsule. So capsule is another virulence factor. If you are surrounded by a capsule, it makes you bigger, and sometimes you're too big for the white blood cells to eat. Sometimes the capsule allows you to be more virulent because it allows better adhesion onto the cells that you are trying to get into. So strep pyogenes produces a capsule and also M protein. So these are all different virulence factors that you may find in strep pyogenes. And the most common guy, are group A strep, when we're talking about infections, is this guy. So what can it do to your skin? Well, it may cause cellulitis. And cellulitis is a red rash that is painful to the touch with cellulitis. It can also cause erysipelas, and this one is raised up, so it looks swollen and the edges look clearish. So we can see this on the face. Sometimes you might see it on the legs as well. And then our last one, erythema, so it's redness, nodosum, and it's red lumps. Lumps are nodules that you're going to find, and typically on this situation is on your legs. It's on your lower legs for this erythema, nodosum, red nodules on your legs. Once we figure out what we've got going on, are we looking at staph? Are we looking at strep? And then what kind of, strep are we looking for? We should be able to get these under control. This situation, though, some of these guys are really fast acting. So this picture is hideous. It's horrible. This is necrotizing fasciitis. You've probably heard of the flesh-eating bacteria, but it's not just one type. If we could just say flesh-eating bacteria was one type, that'd be great, but it's not. It's different types. So it could be strep, that is one of them, but it could also be all of these other guys: Klebsiella, Clostridium, E. coli, Staph aureus, and Aeromonas hydrophila can also cause necrotizing fasciitis. So what is necrotizing fasciitis? It is going to be a bacteria that gets in the skin, under the skin, actually, in between the skin, the epidermis, dermis. We said hypodermis is the fatty layer underneath, and the fascia in between the skin that's going to connect you to underneath the muscle, that area that's in between the skin and the connective tissue underneath. That is what becomes infected with necrotizing fasciitis. So once it gets infected, the skin has no connection to what's underneath, no underlying connection to what's underneath, and the skin can slough off, basically. It becomes necrotic, and you can see these lovely pictures here of that happening with necrotizing fasciitis. So what do you need to do? A lot of times this can work really quickly, like in a matter of hours. This can set in, and sometimes it happens. It's frustrating because even the textbooks, like sometimes it's from a cut on your skin, and I think it was a few years back, maybe 2 or 3 years back, probably 3. That a lady was swimming in the lake and she got herself a cut, but I want to say it was a pretty deep wound. And she was swimming in one of the lakes around here, maybe in Georgia or Alabama, someplace relatively local. And one of these bacteria got in that wound, and she ended up losing appendages that they had to cut off because this was creeping through so fast, and it's very hard to get under control. You can try and, like they're doing in these pictures, debride the skin, try and remove what is infected and try and get a hold of it, but sometimes it creeps through, and the best plan of action is to just cut off the appendage, which sounds terrible. But if it's your life or your arm, you got to make a choice. So these horrible pictures are necrotizing fasciitis, and it's not just one thing. Again, the flesh-eating bacteria could be different types, but strep pyogenes is one of them that could cause this potentially fatal infection. All right, checking in with Sam. Sam was overslept. He hurried through his morning routine. He was shaving. He nicked himself. He had this bump, and it's getting pussy and nasty now where he nicked himself. And went to the doctor to try and check it out. And the doctor says that it's probably a bacterial infection. And she's going to take a swab. She's going to take a swab and see what's going on with it, and maybe culture it and find out what it is. But it is Friday when he decided to come in, so probably results won't be in until at least Monday, because they got to run and culture everything. So she gives him an over-the-counter topical antibiotic ointment. So she gives him like Neosporin, sends him on his way, tells him to change this out twice a day, and she should have the results by Monday. So we want to know what's going on in Sam's skin. Is it staph? Is it strep? And we talked about the different tests that we could run: catalase, coagulase, mannitol salt, different things that we can run to differentiate what is growing on Sam that's causing this infection. All right, different bacteria. Pseudomonas aeruginosa is going to be a gram negative. This one is G negative instead of positive. So if you gram stain this bad boy, it would be pink instead of purple. It is oxidative positive, and it is aerobic. We're going to find these guys in all sorts of places, in the water, in the soil. I can't remember what chapter it was where the girl had the rash near her bathing suit line, and it ended up being hot tub folliculitis, this itchy red rash from Pseudomonas that she picked up in the hot tub. It can also cause swimmer's ear, otitis externa, with this type of bacterial infection. When you culture it, if you're culturing it, and or you're around the patient, and you notice an odor that smells like grape soda, I think that, or corn tortillas. I was gonna say, I think the textbook said corn tortillas. I don't think corn tortillas smell like grape soda, but to each their own. That smell is being given off by one of the chemicals that it is using, one of its virulence factors, basically, gives it that odor. Another thing with its virulence factors, it's going to produce pus, but it can, when it is breaking down cells, it has the ability to grow in environments with low oxygen. So it can mess with the cell's ability to get rid of oxygen. Because oxygen, did I say oxygen? I meant iron. Iron, not oxygen. So it can mess with the cell's ability to keep the iron because it can grow in areas with low iron content. It gets this coloration, this honestly, it's kind of pretty. It's a pretty color for a nasty sounding, a nasty smelling infection. It's blue-green, so it's getting this color from these pigments that it produces, and it will show up in the pus from virulence factors. And also, if you put it under UV light and you're growing it under the right conditions, it will fluoresce. So between all of these, grape-like soda smell, greenish, bluish pus color, and glows in UV light, we should definitely be able to narrow down that this is Pseudomonas. And usually these guys, we can see it with folliculitis and the external ear infection. Usually these are the kind of bacteria that will pounce in a secondary infection kind of situation. Like your immune system's kind of low, and this guy will come along to infect. All right, so acne we talked about in the very first video. Almost everyone at some point has had at least a pimple, if not acne, breaking out in when puberty hits and your hormones start kicking in. Most of us have at least had a little bit of a struggle with acne, a little bit. Some of us are still struggling with acne. But it is going to be a blocked pore where the sebaceous gland is going crazy and the pore gets blocked up. If it is covered, it's a white head. If it's uncovered, it's a black head. And it only turns black because it's all the same stuff. But it oxidizes and it changes color when that happens. Those comedones can be infected though. So it can be infected with bacteria. It is Propionibacterium acnes. I'm just going to call it P. acnes because that is a really long word. So P. acnes can come along and infect your blocked pores. And if that happens, then you might need to put some topical antibiotic on that to try and take care of that. Usually mild acne is controllable, with daily hygiene. If it gets a little, more than you want, maybe some salicylic acid, a skin peel. A lot of acne products do contain salicylic acid in those. Retin A that you can get from your dermatologist will help with mild acne. Moderate acne may need antibiotics to keep it in check. Hormones also help. Females that are on birth control typically see their acne clear up, so birth control is useful for more than one thing. And then severe acne may need other types of medication, but those are things that you definitely need to consult with your doctor. Even consult with your doctor about Retin-A that you might get from the dermatologist, because Retin-A could cause interactions if you become pregnant. So always be thinking about drugs and interactions and what's going on with your body, even if it's something as simple as acne. Check back in with Sam. Sam took that antibiotic over the weekend, on a Band-Aid, trying to make sure, but no improvement. Does not see any improvement. Calls back on Monday. The lab tests are in, and Sam has staph and strep in the wound. They did some tests, passed. They did a glutination test that we talked about in the previous video in chapter 20. They used the latex beads to see glutination. So it's got Staph aureus, and he's also got strep pyogenes with another latex agglutination test. So wanted to know what kind of Staph aureus it is. Is this one of the bad virulent strains? Is it drug resistant? Which one are we looking at? So now we know we got staph and we got strep. What ones? So an antimicrobial susceptibility test is helpful to see, and no drug resistance on strep. Staph showed resistance to lots of different antibiotics, basic ones, but it is susceptible to these two right here. Cephalocytin, and oxacillin. Both of those worked against the staph that Sam has. So he began to use the new antibiotics, and it resolved. Yay! And he's all better by the end of the week. All right, another infection, different bacteria. So this is Bacillus anthracis, and this guy lives in the soil. So like we talk about Pseudomonas, is kind of everywhere. Bacillus anthracis, anthrax is kind of everywhere too. Why don't we hear more about anthrax? It's usually not that bad. The most common type of infection from anthrax is going to be cutaneous on the skin. And so you'll pick these up a lot of times. Wildlife picks these up, cattle, not wildlife, the word is blanking on me. But cows, sheep, goats, those kind of cattle, there we go, livestock, that's what I was looking for, that's the word. Livestock may pick these up from the soil, and then when the farmer is handling that livestock, they pick it up on their skin, and it may cause an eschar, this right here. Mortality rate is really, really low with untreated anthrax infections, and it's really great if you take antibiotics. If you get this, your mortality rate is minuscule with cutaneous anthrax, and you have taken treatment. It goes up though with different types of anthrax. So if it wasn't on your skin, if you inhaled it, those are the worst. It's harder once it gets in your body. There's respiratory, and there's also GI, where you have ingested the anthrax. Mortality rates on the GI are 40%, even if you get treatment, even if you're taking antibiotics, because again, once it gets inside, it's harder to take care of it. It has toxins that it produces against your body. And then the inhaled respiratory anthrax has the highest mortality rates at 45%, even being treated, and 85% of those not treated don't make it with anthrax. Again, most of the infections are cutaneous, and even without treatment, mortality rate is really low on the cutaneous ones. There was, back in the day, in 2001, a person, I've got the links to it and the links from CDC about anthrax, was doing terrible things. He did not agree with I think the way that Congress was acting or the media was handling um, our response to 9/11. And so this person decided to send out anthrax to people he didn't like, the media and other people. And he sent this anthrax through the mail, and people were opening up these letters of white powder inside and inhaling them. And we said respiratory was the worst mortality rate. So I want to say this person killed 3 people in his terroristic attacks. With this, they were able to track down who this one person was because it was a very specific strain that people are not going to have common access to, that this person was using to mail out to people. And so they were able to track down the strain using the different tests, figured out who has access to this kind of strain, figured out who it was, arrested him. And I want to say, I don't think he served trial, or maybe he served trial and took his own life. It didn't end well for this person. And it also didn't end well for the people that he ended up getting sick and killing with his efforts of his terroristic acts. So links are there on that story about anthrax. Let's keep moving on. So these are all the ones of the skin in a handy dandy table. Oh man, I have lost my connection. I'm gonna pull it up again. Okay, so it's sinking. There we are. Here are all the bacterial infections. Let me briefly go back and show you. Oh man, we lost a lot, didn't we? All of our different pictures for our strep pyogenes and the infections from strep, our necrotizing fasciitis, our case study with Sam, getting an update, Pseudomonas, our Pseudomonas imagery. We were talking about the green and blue pigments and how it glowed, and you could see it glowing. Acne and the whiteheads versus blackheads. Our resolution with Sam, and that we were able to test for all of the different things that Sam had, and it was strep and staph, and we figured out the test, and we figured out what Sam had. And then here is the anthrax slide with the links for the CDC and the story I was telling you about the terrorists who was nailing out anthrax. Here is the table with all of the different things in it. Let's move on from skin to eyes. All right, so with the eyes, the first one is pink eye. Pink eye is pretty common, especially in kids. A lot of us may have gotten this at some point in our childhood. And so you wake up and you got like this crusty infected eye that doesn't want to open because it is conjunctivitis. And so common causes of this, it could be bacterial, sometimes it's viral. But we've got Haemophilus influenza, but it could be other things, Strep pneumoniae, Staph aureus, and that is a new one. Moraxella catarrhalis. Any of these guys could potentially infect the conjunctiva around the eye, and it gets inflamed if it has the pus-like secretions where the eye is like crusted shut, and it becomes purulent. We can still treat this. We can treat bacterial conjunctivitis. It's typically just drops that you'll put in there, and in a couple days that infection is all cleared up and you are good to go. But it is really contagious. Again, a lot of kids get this because it is contagious. So you definitely need medical attention. If you wear contacts, definitely take them out and treat your eyes, because you don't want to keep, reinfecting yourself over and over again. Neonates can get conjunctivitis. Typically, neonates, you're like, they're in the womb. How are they getting this? Well, when they are being delivered, that's how they can get this. So how do they get this? If mom is infected with STD, she can pass this on to baby. So gonorrhea, Neisseria gonorrhea, can cause this conjunctivitis. And then also chlamydia can cause conjunctivitis. So now standard practices with newborns, if anybody has, recently given birth, not even recently, at least the last like 15, 20 years probably. Practice is, antibiotic eye drops. Antibiotic cream is in baby's eyes. So anytime you see like brand new newborn pictures, usually got these kind of like really shiny eyes, that's from the antibiotic cream to prevent neonate conjunctivitis. Because if you don't try and treat this, eventually it can scar the cornea, it can lead to blindness, and we don't want that for baby, we don't want that. With trachoma, also caused by chlamydia. So it can cause that, it can cause conjunctivitis. And this one with trachoma is granular conjunctivitis. It can be, and it can infect neonates, but this can also be spread in other things. So usually we don't see this in the US. It's usually in other places where preventative care or easy access to medicine is tough to get. But somebody, has eye infection and, they took their shower and they're wiping their face and then they put their towel down and somebody else, maybe wipes their face with that towel afterwards, or they touch their face and they touch something else, and now you got fomites spreading this. Or insects can spread this too. There are flies that will land on the eye and the mucosa, and then you swat them away, but then they go and they land on somebody else. That can also spread it this way. So this is trachoma. It needs to be treated with antibiotics. It can cause the eyelids to swell and then they will eventually curl in. And that is not good. We need that to be treated before the eyelashes curl in, because obviously eyelashes curling in onto your eyeballs would be super painful and scarring of the cornea. We don't want that to happen. We need to take care of it because it could lead to blindness if surgery doesn't happen. Bacterial keratitis could be staph epi, it could be Pseudomonas. Staph epi, so it could be both of them, or just one of them, Pseudomonas. And if you, again, we're talking about eyes, everyone who's wearing contacts, please, take them out, wash them in the solution like you're supposed to, make sure you got clean hands before you go touching your eyeballs, all that good stuff, because nobody wants conjunctivitis, nobody wants keratitis, these bacterial infections. All the different ones in the handy dandy table for bacterial infections of the eye. All right, so next video we will cover the other types, the other pathogens for skin and eyes.